the time to call in. On behalf of the 5-star accredited Fort Bend Chamber, I'd like to welcome everybody to this webinar. My name is Mike Dotson. I'm the chairman of the Healthcare Division, and we hope that you and your family are healthy and safe. We'll go ahead and acknowledge our sponsors: CHI St. Luke's Health, Sugarland Hospital, Q People Inc., Fort Bend Medical Society, Memorial Hermann Sugarland Hospital, and Houston Methodist Sugarland Hospital. Our panel, I'll start with Rosa. Rosa Fletcher is the Regional Administrator at Houston Methodist Primary Care Group. She has over 20 years of healthcare experience in process and technology. She focuses in financial and change management and has worked in access-focused strategy. She holds an MBA, is EPIC certified, and Lean Six Sigma belt trained. Next panelist is Jared Lewis. Jared is the Ops Manager for Houston Methodist Physician Organization in the South region. He's played an integral part in managing system-level projects to completion, including but not limited to EMR integration, telemedicine, and physician onboarding. As an operations manager, he monitors daily operations for multiple specialty practices, conducts financial analysis to ensure practice performance aligns with institutional goals. Next up is Dr. Sapna Singh, Doc's board certified pediatrician. She works for Texas Children's Pediatrics here in Sugarland and as the past president of the Fort Bend Medical Society and a delegate to the Texas Medical Association. She recently completed Harvard Medical School's Global Pediatric Leadership Program and has a keen interest in improving access to quality healthcare for children in innovative and cost-effective ways. Our last panelist is Janice Suchyta. Janice is legal counsel at Seyfarth Shaw. She's also worked in the FQHC setting as a general counsel. She has a unique operation-oriented perspective and has a practice where she advises clients in their day-to-day operations, also has significant experience in 340B drug pricing, implementation, compliance, and advocacy. So with all of that said, please join me in welcoming this esteemed panel, and we will go ahead and get started. So Janice, I'll start with you. If we could talk through and kind of give the folks on the webinar a brief overview of telehealth, some of the relaxation of rules around telehealth, and any special nuance associated with COVID-19.
All right, thanks, Mike. I'd be happy to do that. And I think as everyone realizes, probably this time last year, most people calling in today, or even all of us sitting here, weren't familiar or had even heard about telehealth or telemedicine. Unfortunately, with the current public health emergency, all of that has changed. And I think the word telehealth has become almost common in our vocabulary and almost a day-to-day experience both for providers and patients here in Fort Bend County. I think a really good common definition of telehealth is improving a patient's health through the two-way interactive communication between a patient and a medical provider. As we're going to learn more about today from the other panelists, that communication can be like through a two-way video, as we're doing today, smartphones or other technical platforms. In regards to what has happened for medical health regulations, telehealth has been a huge player in regards to the changes in the regulations. When the public health emergency was instituted on the federal level, prior to the COVID-19, government-sponsored health coverage, people know that as Medicare and Medicaid, and also private insurance, they had strict guidelines in regards to when telehealth was allowed. But that's all changed when we had the stay-at-home orders, and both the government at the federal level and the state level realized that they had to prioritize care at the hospital for COVID-19 patients. Obviously, you don't want people not to see for their health care during a public health emergency if they don't have COVID-19 needs. So as a result, public policy in regards to federal and state level began to relax and to make telehealth more accessible to patients and providers. We're going to learn more about the different services that are being offered under telehealth. you'll see that your primary care services are now allowed under telehealth, even specialist services, behavioral health, speech and hearing therapy. So basically what that means is it doesn't matter where you're at, you can still get all of your healthcare needs taken care of through the home, through a technological platform. You don't have to have it in the doctor's office anymore. In regards to other relaxations, in regards to what type of providers can do telehealth, we're going to learn more about that from the other panelists today. But it's not just physicians. Nurse practitioners can also provide you care, physician assistants, certified nurse midwives for obstetric needs that still go on during a pandemic, licensed clinical social workers and psychologists for behavioral health needs, and even dietitians. I think what's interesting too is that during this time, if you need to see a new provider, under the old rules, you couldn't see a new provider under telehealth. You had to see them in person. That's no longer.
I think we lost Janice. Hopefully she'll ring back in. I think that was a really, really good summary and a good place to start. So I think we'll kind of jump in and we'll tee this up. And I'll start with you, Dr. Sen. Then we'll move to Rosa and Jared. And then Kim and Rakesh from Memorial Hermann are on as well. So we'll go to them kind of as a third version of this topic. But what I would like is each of you to talk about your organization's capacity in telehealth, centered around what types of services are being offered by discipline, volume, really just kind of how everything is working on your end. And I will let you guys take it from there. So Dr. Singh, if you'll start, that'd be great.
Sure. Yeah, thank you for having me. This has been really an interesting time. I mean, obviously, a crisis necessitates innovation, and here we are. And telehealth for me personally, I'm a pediatrician, has been really fascinating because it's changed how we take care of sick patients, which is bread and butter for what I do on a day-to-day basis. But with the COVID crisis, obviously we had to come up with solutions that were not going to create exposures within the clinic settings. And we're also going to direct patients away from urgent care and ERs for things that didn't necessitate being there. Obviously to kind of keep that burden away from those facilities. In my organization, we literally ramped up what I think was probably a 2 to 5 year plan for increasing telemedicine access, literally within 2 to 3 weeks. We went from having just a few providers doing simply COVID-19 triaging to now we're up to hundreds. I mean, we're definitely going to the hundreds in terms of how many visits a day we are now conducting via telehealth. It's been really, really helpful because we, especially as physicians in primary care, fear that people would stop accessing the clinics out of a fear of being exposed to COVID, and therefore we would lose access to knowing whether they were suffering from illnesses that needed to be addressed. For children, a lot of those issues necessitating specialist visits actually have been handled as new patient visits with our subspecialists. And the parents we've had really great feedback. The concern always was, if you're not touching, seeing hands-on with a patient, how do you maintain the relationship? How do you maintain the quality of care? I think we're really kind of surprising ourselves with the fact that patients are very happy with the services they're being given. And this is great to be able to face-to-face see somebody in their own environment, and to be able to access them in a convenient way for them while also protecting them through the pandemic.
That was really, really good. Thank you. Jared, if you and Rosa want to just kind of jump in here, that'd be great.
Sure, absolutely. Brian, if you can pull up, I put together a short slide deck too, but if you'll pull up slide number 2, Brian, Houston Methodist has spent a significant amount of resources in terms of preparing for video visits. We've actually started offering video visits back in 2016, if I'm not mistaken, and it's grown to this thus far. The proliferation of it definitely changed with COVID-19, and it forced a lot of our physicians' hands to do something that they initially weren't very comfortable with. But we'll speak about that a little bit more during our conversation. But as I mentioned, we offer several different platforms, so virtual urgent care, MyChart video visits. So MyChart is the mechanism with which patients can log in and communicate with their providers, request medication refills, request appointments, things of that nature. E-visits is another component of our MyChart app where you can fill out a questionnaire and get a physician's response in terms of next steps for your care via MyChart messaging. And then something also that was mentioned earlier by Janice is, it's not just videos. We've seen a real lax by our payers in terms of allowing us to communicate with our patients via telephone. Obviously, we've been doing that for years, but being able to document and it being a legitimate encounter in terms of billing and including that in the patient service. So telephonic visits and consults are something that we've also rolled into our, telehealth repertoire here at Houston Methodist. And I'll speak just a little bit more too about the virtual urgent care. So virtual urgent care is 24/7 access. So it's not just your typical 9 to 5. You don't have to be an established patient here with us. As long as you download that app, Ryan, if you go to slide 3, you download the app, you can get connected with either a Houston Methodist physician or a physician from an organization we've partnered with to, again, have that wraparound 24/7 coverage for various needs. So the cost of entry is very low, and again, it brings that care to you at home. So Rosa, I didn't know if you had anything else to add regarding the services we currently offer.
Yeah, no, thank you. I think you explained it pretty nicely. I think slide 2 kind of just highlights at a high level all the different services that we have available. As Jared mentioned, so we have Epic, so we had MyChart set up. There are a lot of these different platforms were already kind of set up, but that also doesn't mean that every provider was using it. Like Dr. Singh mentioned, we went from one day to the next day having to be all hands on deck to try to get providers, acclimated to these technologies and make sure that our patients were aware that we were offering all of these during these times. And so slide 4 kind of talks about the growth that we experienced. So if you look at our baseline, kind of just adds to where we were prior to COVID and the need to shift and be innovative and creative to meet the patient where they needed us to be, which was home, and be there, and continue their care. They didn't want to obviously come to the office. We didn't want necessarily to have them here as well, but we wanted to continue to provide the same level of service to them. So you see how we went from the baseline in January, February to, March, April, May, how we saw that shift from in-office to virtual. So, similar experience as Texas Children. We had to go from one day to the next to get everybody onboarded and be available for the patient.
Yeah, okay. That's obviously quite a bit of spike here lately. Kim, Rakesh, do you guys want to jump in and talk a little bit about Memorial Hermann's version of telehealth and what's going on there?
Yeah, excuse me. Thanks, Mike. My name is Rakesh Mehta. And Kim, do you want to introduce yourself before I jump into telehealth?
Hi, sure. I'm Kim Gemza with the Memorial Hermann marketing team supporting Everyday Well and our virtual care offerings.
Thanks, Kim. So yeah, Mike, we had a fantastic sort of a team and a system-based approach. Similarly, I joined the organization 4 months ago, but I've seen, like everybody mentioned here, the world has changed on us, the new normal in healthcare as we kind of define this going forward. I think we took a very system-based approach to this and led by our CEO, Dr. Callender. and his executive team down, we looked at the entire patient continuum and journey, right? So we saw the different settings of care that a patient looks for care from Memorial Hermann. And just starting off those different settings of care, we quickly stood up platforms that we saw as gaps, anticipating a scenario-based planning and where those gaps might exist. So very similarly, we had a 24/7 video-supported platform for our consumers and patients for low acuity conditions and some of that triaging for COVID, because early on there's a lot of panic in the community out there. And then a lot of that was actually provided by our own physicians. So there was a tremendous support by our physician organization, both our employed and clinically, integrated network. Not only that, the care continuum, as we think about, as patients kind of like waited out more and more, some of the chronic disease patients and patients needing just normal visits. So our physician organizations have been doing thousands of the virtual office visits, as we call them. So the patient actually sees their primary care physician so that they don't have to see somebody who they are not used to seeing. So that has been a great success over the last couple of months now. We also see a tremendous impact in the inpatient setting, where obviously just to keep our providers safe and keep the patient actually engaged with their family members because of some of the restrictive visitor policies and such. So we also had a bunch of iPads and tablets inside the inpatient setting, outside in the tents and everything. So telehealth was like pervasive and everywhere. And then also closing the loop on the chronic disease patient side, right? So you have these patients that cannot keep up with the COVID sort of isolation. So remote patient monitoring has been sort of a big thrust for our organization also. So how do you keep the diabetics and people that have hypertension and coronary artery disease and some of those comorbidities, how do you keep them engaged? And how can we collect the data coming from these patients on a daily basis? And how do we, as a care management organization, also look at the data and allow us to kind of like ping some of those patients and ask them to take better care of themselves? So it was a very holistic system-based approach along the patient care journey. And I do want to sort of conclude also by saying, so this is, we're not out of the woods yet, right? So the state may have reopened and hopefully there is no second surge, but again, that planning continues at Memorial Hermann. We are looking at different avenues with the CMS waiver and such. We are looking at all settings where patients, if they are still reluctant to come back in again, how do we provide that care at distance, whether that's gastroenterology, orthopedics, oncology, and transplant clinics. So we have a bunch of hospital-based clinics that are also partaking in this same program. So I think, like somebody mentioned, Dr. Singh mentioned early on, we are seeing unprecedented growth. Sometimes it's 15 times what we saw in a single day. We are seeing in the midst of COVID. And we're all speculating what the new normal is going to be, but it's not going to be as before, right? So it's never going to be a status quo for telemedicine going forward. And absolutely, we are primed to support our community as we move forward. And if there is a second surge, I think we are very well positioned to take care of the patient along the care journey.
Kim, did you have anything you'd like to add?
Well, I think it's important, and just kind of continuing on the thread that, just really trying to understand how our patients want to engage in their healthcare is, we're still learning that, right? Just because everything that we, through this pandemic, we've just been learning. And so I think it's interesting that we'll continue to garner these lessons learned of how our patients want to engage, because like Rakesh said, they may not be comfortable yet coming into the facilities, wherever it may be, hospital or primary care physician's office. So I think, it's going to continue to evolve. And, so I think just where we're at, just making sure that we're here for our community and letting them know that, whether it's in person or, from a virtual capacity, we're here to help our patients with their healthcare needs.
Awesome. Thanks a lot. That was all really, really good. Ryan, do you have a video that kind of shows the patient experience from Methodist's side? Is that something we can run?
The video is a little long, but Ryan, if you skip to around the two minute mark, that'd be helpful.
Yeah,
be on
sounds
slide.
good. Give me 1 second. Yeah, sorry, my screen isn't sharing. Hold on, let me try this. All right, let's try this one more time. Here we go.
While Ryan boots it up, so what Methodist has done, I think, a really great job at doing as well is, you know, as we transition to really ramping up our video visits, you know, how do we bring patients along this journey in terms of bridging the gap between those who are more technologically advanced and those that aren't? So we've put together a whole host of resources just to walk patients through step by step what you should do, how to do it, and if you have an issue, here are some things you can do to try and troubleshoot. So this video that Ryan's queuing up, this gets sent out to each video visit that is scheduled via text message. So we have a really comprehensive text messaging platform where we can communicate with patients via text, but also send them links, documents, and so on and so forth. And they can play this video from the comfort of their own home, iPad, Android, whichever, and then really get acclimated to what to expect and how to be prepared for the visit to mitigate any kind of technical issues when it comes time for their appointments. Obviously, we spend 20 minutes per patient sometimes just walking them through, and there are some patients that still have flip phones that want to have a video visit. There's patients that have their laptops ready, but they don't have a webcam or speakers. So, walking patients through, getting them prepared, and if necessary, rescheduling that visit or just flipping it over to a telephone visit. So we've seen the whole gamut here, but I think, again, this video just sums up how nicely we've been able to coordinate the technology and making it easier for patients to see their physicians.
Okay, well, that was really good. I think we're having a little bit of a technical difficulty. Ryan, I'm going to push through. I'm sorry.
Yeah, I think we have the video ready. Here we go.
Please download the MyChart app by going to the Google Play Store on your Android device or the App Store on your Apple device. In the search, it's MyChart, one word.
Yeah, Ryan, it's not running. I don't think on this end. So.
It's on a separate.
Yeah, let's go ahead and just X out of that, Ryan, if you can, and we'll push through with some of the questions.
Yeah, and if I can add to Jared's comments, so I think one of the reasons why the volume for some of the clinics didn't even skip a beat. I mean, we just kind of continued being as busy as we were with seeing patients in the office to seeing them virtually. It was just almost the same volume. Was because of all these different platforms and being able to sort of queue up that patient for the provider. So by the time that the provider was ready to see that patient, the med reconciliation, all sort of the pre-charting, if you will, was already kind of completed, with the medical assistant. We walked, the front desk walked the patient with, downloaded the app, making sure they looked at the video. There was a lot of communication that went out before that patient even got in front of that provider. And interesting data on slide 8 kind of shows, one of my clinics, one of my primary care clinics is internal med. So they have a high Medicare patient population, lots of elderly, patients. And if you look at slide 8, it kind of shows how, age wasn't really a determining factor for that clinic. We walked the patient, like I said, we queued up that patient ready to go, and it didn't really matter, their age. They still downloaded and they still completed the video visit, whether it was, through the MyChart portal. I don't know if we mentioned, but we've also, if, they weren't able to download and use it via MyChart, Doximity was an option that, to be honest with you, I didn't even know that existed until this all kind of happened, that there was a platform out there that, we could use as well. So there were some backup options, and then telephone encounters were kind of like the last one, if you will, once we sort of exhausted all those other options. But age didn't seem to be, a factor, because of sort of all that pre-work we did to get that patient ready for that provider at that time.
I think that's a really good transition, and I'm sorry, panelists, but I'm going to jump around a little bit. Dr. Singh, I'll tee this up for you, and then if the Memorial Hermann folks want to jump in thereafter. I know we've kind of hit around this, but if you can talk a little bit about response from a patient side, providers, what's the data looking like, age, demographics, and then address maybe any myths or surprises that have happened as you've transitioned through this process.
Yeah, so I think what Rosa mentioned is actually super important, that with introducing something this new to the model of healthcare as we were used to it, training on both sides is extremely important. And so my organization, Texas Children's Pediatrics, has taken extensive amount of training with the physicians as far as how to interact with patients in this setting, because obviously for us, our age and demographic can be a 2-year-old who won't really speak back to us and doesn't want to sit still for the visit. And so how do you kind of engage the parent to help you complete the parts of this visit that will make it useful? The physical exam, the history, vitals even. How do you train parents or patients at home to get a good weight on themselves, or get a couple of very basic vitals, so that the physician can kind of work with that without us being able to actually do it? So training, not just the physicians, but also patients in the technology, but also in the ability to get through a visit in a useful way. So for example, where the camera needs to be so we can see your face, how to kind of adjust lighting for certain things. I mean, it's been fascinating because we're all learning together. And I think what patients have appreciated from what the feedback has been on our end is that we're keeping them safe and we're still providing care. And we're still providing care at a really high quality. There was definitely, I know in our organization, a concern that antibiotic stewardship, which is basically the overprescribing of certain medications, would ramp up because we simply couldn't make decisions with all the information at hand. And in fact, the statistics so far have gone against that. Physicians have actually been more conservative, but patients are also more willing to follow up with us if they have the option to do a telemed visit. They're actually really okay with, sure, I'll call you back in 2 days and let's do this again if things aren't working out. Whereas that would have required in the past taking off from work, getting in the car, getting the kid out of daycare, coming back into the office. The time and the inconvenience that was there is kind of removed with this platform. And so my hope moving forward is, which I think is going to be the 2 biggest impediments to this continuing as a new normal, is whether or not the reimbursement will continue to be adequate for the service provided, as well as whether the liability and the protections for both physician and patient will continue to be realistic in terms of what we can provide this way.
Really good. Kim, Rakesh, would you guys like to chime in as well?
Yeah, no, I think those are great points from Dr. Singh. I think we experienced some of the same in terms of, I call it forced adoption, right? So this crisis sort of forced a lot of stakeholders to adopt, not just the patients, but also providers. So if you think about a technology dissociation curve, there's always those innovators, and then you have early adopters and late adopters, and then people who lag. So we saw somewhat of a similar sort of curve in virtual medicine over the last couple months as well. I think a lot of training sessions, and gosh, at some of these training sessions that some of our information services department held, we used to have almost 800 attendees. So it's not just the providers. You got to keep the fact that you have a patient access reps, the front office desk staff. It's all a new paradigm for them as well. So how do they answer questions if somebody is lost and some patient is kind of struggling with onboarding or submitting a form? So these are entirely new processes that we stood up in literally a couple of weeks, right? So there was tremendous team spirit which came together to make this a success. Obviously, as anything, there were hiccups and gotcha and learning moments, but that's all good. We are kind of like rolling all those learnings into like a path going forward. Also, I think patients, like somebody mentioned, were way more receptive, right? So there's always this sort of, I don't want to call it speculation, but some sort of a perception that this is very fancy. But if you think about it, even the senior demographic talks very often with their grandkids on a FaceTime or similar app, right? So lo and behold, when they actually came to the actual consult with a physician or a provider, it felt very similar to that. Yes, there was some amount of that pre-work where a medical assistant actually has to do the form intake and such. So all that training actually did well. We are still learning, behooves us to keep learning. And I think in terms of like, there was a question about what's the new normal. I think the question also comes back to reimbursement and some amount of behavior stickiness as we anticipate both from the providers and patients. So this has done that phenomenal thing, right? So it has forced that adoption and behavior change. Like they say, behavior changes only when there are like very specific crises on or relocation sort of a thing. So that has happened, and we want to see how much of that behavior kind of like sticks both on the provider and the patient side, and what are the enablers and what are the detractors to that sort of behavior change. So some of the reimbursement, I think payers are kind of taking notice of how much of that adoption has happened. So some of the metrics that Dr. Singh mentioned, the quality metrics, is there inadvertently too much of antibiotic prescribed or some sort of neglect in the system. I mean, we'll have a lot of data coming out of all this, because it's some reports are saying we could see these visits stop about 600, 700 million across the year. So depending on how this sort of COVID pandemic progresses, we don't know where it'll land. But I think there are a lot of great lessons, and we are all learning. It's almost like I call it building the plane as we fly sort of a thing in certain instances. So we are trying to be most prepared and supportive of the community, and patients have done their bit. That is very encouraging, and it's going to be, I think, in the future, it's going to be a sliding scale. The new normal is going to be, at least over the next 12, 18 months, or however long it takes for the vaccine to be widely available, mass produced and mass administered. It's going to be that sliding scale where we'll see different scenarios have been sort of posited, and we'll see some of this telemedicine advance to more of adoption and then slide back to less. But we won't know till we see the future. So I think most of us are now ready, and I think the first sort of crisis taught us a lot, and we're all waiting what the new normal looks like.
Really good. Thanks. Janice, I see that you're back on. Can you hear us?
Yes, I can.
There she is.
Yay, technical difficulties solved. My apologies.
I'm going to scroll back up here. The question I have, and I'll let you handle the legal side of privacy, and then we'll talk to some of the medical folks and just see what's actually happening on the ground. So I think a main concern, I think for most patients, would be how private is this and what protections are offered to me?
Yep. So like we talked, there's been a relaxation in regards to the regulations as to what type of care and what kind of providers you can see under telehealth. But another huge law that everyone is familiar with, or that you should be, especially as a patient, is HIPAA, which means that your patient health information, all of the private data in regards to your medical condition, is supposed to be kept private by your provider. Mike brought up a good point. Okay, everyone's concerned that now I'm seeing my doctor over these technological platforms. Everyone knows about different platforms getting hacked, things of that nature. So I think everyone is concerned about, is my data still going to be private now that the technology is being spread wide open? At this point, the regulations on the federal and state level under the public health emergency is that the HIPAA regulations have been, and the enforcement has been waived. Under the policy guidance that they want, as the doctors have said today, we want to encourage everyone to use telehealth. So in case there is some type of data breach, or if your information is not, quote unquote, as private as it should be under these different data platforms, the federal government is not going to come in and do these enforcements as long as this public health emergency is in effect. When that's going to stop, no one knows. So in regards to privacy, as we've heard from the folks at Methodist and Memorial and all of our providers here in Fort Bend County, most of them are using telehealth through their patient portal, their electronic medical records, which have very good security. People need to be outside of large hospital settings, especially in rural settings, smaller providers, things of that nature. They may be using different technological platforms that are not as technologically secure. And the federal government has said you can use Facebook Messenger to communicate with your folks during this time, Skype, things of that nature. So yeah, that may not be as private as other platforms, but that's still going to be allowed. But the federal government says you cannot be using to communicate with your patients is public-facing platforms, TikTok. Let's hope no one is using TikTok. Facebook Live, things of that nature, which I'm sure no one is using. But at this point, yeah, there has been a moratorium in regards to enforcement because they want providers to use different platforms that are convenient and user-friendly for their patients. I think we've seen today that most patients are being able to use their patient portals through their electronic medical records. Going forward, as we're talking about the new normal, I think these HIPAA waivers will go away once a public health emergency ends. Hopefully that'll be soon. But we're going to see that they're going to encourage people to use the patient portal, which is very secure through electronic medical records. And more than likely, once COVID goes away and we're back to a normal regulatory environment, you're not going to be able to use Facebook Messenger and things of that nature.
Really good, thanks. Dr. Singh, what are you seeing from your patients in regards to fear and maybe I don't want to do it because it's not private, and how do you assure people that it is and it's the best course of action for treatment?
So we actually fortunately are also using our portal through Epic as well, and we have been extremely strict. Our organization has actually not allowed us to really step outside of the confines of our platform that we're using through Epic. So their information is encrypted, it is secure, it's all being filtered through our portal, and it has created some issues because if you can't access that, which has kind of been our issues on the user end, they're not able to necessarily engage on that platform. Either they can't download the app, it doesn't download and open it correctly. So there's been a lot of issues on that end, but I think that those encounters have then been flipped over to a telephone encounter, and we've done the best that we can. So in terms of privacy within our organization, we haven't had concerns as far as the information or what they're sharing with us would necessarily then leak out or be shared in any other way outside of the organization itself.
So one of the things that you mentioned during our prep conversation was that you're getting like this new window into your patients' lives. So if you've got them on a video screen, you're seeing a whole lot more than you would see in an exam room or your office. So can you kind of talk through that and kind of talk about the change and what it's doing for you and how you're able to sort of practice beyond the norm?
Yeah, so I think what's fascinating, this kind of happened in a visit a few weeks back. I had a toddler that I was checking out for something, and he was strapped into his high chair, but he wasn't buckled in. And I'm looking at this, but I'm like, he needs to be buckled in there because he might fall out of that, and then I'm going to get called for a fall from 3 feet, So it's interesting because you get a window into their environment. You get to see where our kids are living. I have had a few friends who are geriatricians who've told me that this has helped them to really look at the environment in terms of safety for elderly patients. They've been able to kind of look around and say, wow, that's a lot of clutter over there. I'd be really worried about you falling if you kind of were in the wrong place near the doorway. Or it's just, for us as doctors, we hear the report that we get in the office, but to see in real time what's happening, how someone lives, what their environment looks like, it's a huge part of the history that we just have never had our eyes on. And it's not part of the visit that you can really sit and discuss if you've got 15 minutes to confront, one or two issues. But now you can actually look at an environment and be like, wow, this is, now I know where you live. I know what your home looks like. I know what, and I've been just completely intrigued by seeing mom with 3 kids, and they're like all over the place and they're on top of her and she's trying to talk to me. And you suddenly develop a respect for what someone's day-to-day life looks like beyond just what I'm dealing with as a physician. It's been really eye-opening. I've appreciated that aspect of knowing about my patients that I just never had the opportunity to see before.
Thank you. So we're getting really close, and I'm trying to manage what's coming in through the chat. I think we've addressed most of the questions that are there. So we do have quite a few folks on as presenting. So I'll kind of walk us through this, and then if anything comes in the chat, we can maybe pivot to address it. But I think we've talked a lot about relaxation of rules. We've talked a lot about scale. So as we close and kind of everybody give their ending remarks on what's going on, are we at the tipping point, i.e. the point of no return, and that telehealth will be a more permanent fixture in healthcare moving forward? And I think we'll start with Rosa and Jared, and then I'll kind of move us through the people that are on the call.
Yeah, so yes, I definitely agree that telemedicine is here to stay, for sure for us. We actually today I'm working on what our templates look like for June and July. And I'm getting questions from patients and providers. Are you going to allow some virtual blocks? Are you putting blocks in there so I can still see some virtual patients? This is from my providers that before COVID were like, I don't know about telemedicine. I don't know if you can really use that for my patients. And some of those same providers are like, you're adding blocks to my schedule, right? So I can still continue to see virtual patients. And so, yeah, we're excited to continue on this journey and continue to provide these services to our patients. And again, within reason, because we're kind of still waiting to hear from all the major payers to see if they're going to extend their deadlines. Most of the payers are going to stop paying at the end of May, some for early part of June. With Medicare, I think, and Medicaid continuing to pay, if I remember correctly. So we're hoping to kind of hear from more of the payers, because that's going to, really drive how much we can continue to offer. But we're all in, and our providers are excited to continue on this telemedicine, journey. So yeah, I think anything else you want to add, Jared?
Yes, just to echo what Rosa said, this is across all specialties. Physicians got a taste of it, and they're going to want to keep it in their daily practice. And I think for the most part, we're very supportive, and until it doesn't make sense. But also, I think, concurrently with COVID happening in the hospital, it's how do we make patients feel safe coming back and seeing us? What are we doing to help make them aware of the protocols we're putting in place for them to come see us back in the clinic? So yes, we've ramped up the video visits, and this is going to be our new normal, but living with this, with COVID, is something that I think the leadership here has placed a very heavy focus on. And I think even in our clinics, we're spreading the chairs out 6 feet apart. We're staggering our schedules so patients spend less time, if any, in the waiting rooms. They're getting roomed immediately. We're cleaning things like crazy and making sure we have the correct stock, PPE, wipes, disinfectant. So we're doing those things additionally, we're screening patients when we're scheduling them, giving them a mask if they don't have one. So we're doing all of these things to make sure that when you're ready, we're happy to see you. Mm-hmm. So that's the new normal we're kind of balancing in. And I think making sure that our patients kind of come to terms with this new reality and are willing to face it, we're here to help you, regardless of how you want to conduct your visit and see us.
So Janice, I'll kind of tee up the same question for you, but also if you'll add any expectation on any of these temporary relaxations sort of moving forward, whether it be centered around billing or privacy or any of the things that we've talked about.
I think in regards to the privacy, I think when we get back to a non-public health emergency, non-COVID situation, the HIPAA rules will come back into effect. And I would imagine the feds are going to want providers to use telehealth through their patient portal, through Epic, things of that nature that have the encrypted, secure environment. I think these temporary relaxations are just so that you can get patients seen without having to go into the hospital. In regards to, is telehealth here to stay? Market trends and reimbursements, I've been noticing, I just read an article today, Medicare Advantage, Blue Cross up in Minnesota has just stated that they're going to extend reimbursements for all types of visits for their population up there, especially in regards to the seniors. Seniors like telehealth in the sense of they don't have to go in. Like one of the doctors was saying, it's very convenient, especially for young mothers, but especially for the senior population, it's easier for them. You don't want them out in this type of situation. So I think if we see quality metrics maintain, peak, and the payers see, both private and federal, see that telehealth can maintain or exceed quality metrics, maybe providers can see more patients in that regard. It's efficient, things of that nature. It's safer. So I think you're going to see a trend that this will continue and that this will be a new normal. And it's very exciting for everyone.
I agree. Thank you. Rakesh, Kim, I think same question, but what opportunities are you guys looking at as far as expansion? Obviously, there are opportunities probably in rural areas or folks that normally, for whatever reason, couldn't get in. And how much of that strategic kind of visioning is happening at Memorial Hermann?
So Kim, do you want to go first from the marketing and demographic perspective, and I can close with some of the strategic comments?
Sure. So I think, kind of to dovetail into what everybody's saying, we know that this is our new normal, right? So we're positioning in that regard. So oh, my camera's not on. Okay, sorry about that. And so we're just really trying to position ourselves around just making sure that we meet the consumer where they want to be, right? So I think in regards to opportunities, just really making sure that we're in a consumer-centric environment, that, our website and how we're engaging with our patients is how they truly want to be communicating for their healthcare needs, right? So everything from, just taking a look at our Everyday Well, which is our online portal, so where our consumers do engage in their virtual care appointments, so, in their interactions. So just making sure that's really easy and streamlined for our consumers to use, so that, and to the point of, whether it's young or the seniors, everybody's using virtual care. So we want to make sure that it's a good and seamless experience for everybody. So, and then I'll let you, Rakesh, kind of talk about the opportunities that we're looking at from kind of more operational.
Yeah, actually, so strategically, even in the pre-COVID days, I think there's tremendous potential, right? So the way we define telemedicine is not just the people immediately think about the audio video consult, and that's sort of the hallmark of telemedicine. But if you think about the breadth and span of telemedicine, it is across the care settings. And you think about mobile health applications, you think about things like that a diabetic or a diabetes patient doesn't have to go to a physician, but can fill in their sort of like, what are my readings for today? And then somebody can see that trend and then actually make sure that it's not trending in the wrong direction. So that's just one example of how telemedicine kind of like that scope is just way beyond the conventional audio video consults. I think about remote patient monitoring for a recent patient that has been discharged from the hospital, right? So there's tremendous value in things like those. CMS is actually agnostic of the recent waivers. There's a bunch of things that we can do in terms of virtual check-ins that a patient doesn't have to come in. The patient can talk with a physician, and it has to be with an established patient. but the physician can make sure, hey, if you don't have to come in, they can consult over a telephone. It's smaller payments. It's not as big as an actual 15-minute consult. But there's different avenues that CMS already had opened up prior to that. So we're still in that process of absorbing those things and remote patient monitoring and mobile health applications and such. And like Kim mentioned, there are different demographics, right? So those different demographics like different things, the millennials, and they some of that stickiness to a PCP is not established. They just want, it's an episodic and a transactional behavior. Somebody mentioned about seniors, and actually that's a perception, right? So seniors are actually very loyal once it comes to, they like virtual kind of a product. They are the ones who will actually be a big proponent for something like that. So we are learning all these things, and strategically, like the question was, we do see ourselves sort of pivot. And we always, my mission statement and the way we describe telemedicine, the virtual health is sort of like an augmenting factor, right? So it should never stand up between the physician and the patient. It should actually be augmenting that physician or the provider-patient sort of interaction. So wherever it has that place and appropriate clinically, with all the right metrics achieved, I think there's a lot of scope for virtual health. And like you mentioned about rural healthcare, gosh, there are like, if I'm correct, there are 35 counties that don't have a PCP. There are so many counties that in Texas, being such a large state, that lack some of the specialist access. So things like inpatient telemedicine or telestroke. We have one of the, partnering with UT, we have one of the best stroke programs in the country. And it's a very robust growth that we are seeing. So how do we expand those access to a specialist, right? So we cannot lose sight of that big gap in the market, that specialists, that's a very scarce resource, just like physicians across board. But how do we give access to specialists? So there's so many things that can be done in rural, actually, from a CMS and from a reimbursement perspective. That is actually a sweeter spot, because even if CMS were to roll back everything, which I don't think anybody here foresees that happening, they do allow rural reimbursement. I think I'll conclude by saying, I think like the CMS administrator, Seema Verma mentioned, I think the genie is out on this one. It's not going back on the bottle again. So it'd be very shocking to everybody, and not just the proponents of telehealth here, but everybody, including providers and patients, if this went back to sort of like day zero. So we don't anticipate that happening. But again, we as a system have a plan in place, even beyond the reimbursement, to look at the true value capture of how we can provide that access and expand specialist access, and where the patient wants to be treated, when the patient wants to be treated, in a setting that the patient wants to be treated. So we can, I think we are pretty confident we'll fulfill that anyways. Thank you.
So Dr. Singh, you've got the last question. And I think we've gotten a lot on the idea of where we're going, but in the situation we're in right now with COVID-19 and a pandemic, how do you balance the telehealth and the piece where I've actually got to see you because you need to get the shot from me? And what danger is out there if we have a lengthy amount of time where kiddos aren't getting the immunization panels that they need to get? And how are you thinking about that, working through it?
No, it's a great question. In fact, I think telehealth has provided us with a way, as Jared had mentioned earlier, to provide that comfort to patients that the environment they're being seen in is not going to create an exposure risk, which, by having families shelter at home, stay at home, and then to call them into the clinic and potentially their fear is, well, will I catch it there? That did, for a period of time, I think, prevent parents from coming in for vaccinations. And, look, in the scope of a pandemic like COVID, we also cannot handle measles outbreaks, and we can't handle, outbreaks of diphtheria because babies aren't getting, or pertussis, they're not getting their shots. And you're absolutely right. I cannot virtually give a vaccine. There's plenty of kids who wish we could do it that way, but I cannot virtually give vaccines. And so to provide that environment where I can promise a parent that we are screening, we are taking all the precautions necessary to make sure that we are seeing well kids, well children in the clinic, we've been able to actually boost our volume, and parents are coming back. I mean, we're rocking and rolling. I had a clinic this morning that was so busy. I'm going back to clinic again. And it's refreshing to see them coming in and that they feel safe, they feel comfortable. Telehealth, I think moving forward, hopefully with the quality metrics, may improve compliance in the patient realm as well. Asthmatics who would not come in to see me for the regular asthma checkup because, well, I'm not sick right now. Well, I can do a telehealth visit and probably capture them on a 3 to 6 month basis and monitor things before they get bad, which for adult medicine, obviously, chronic conditions, hypertension, diabetes, so many things that people ignore. If you're able to conveniently interact with your doctor and give your doctor good information, you can create plans that improve compliance for all of our patients across the board in this platform. So I really hope that with advocacy, and we need the help. We need the help from our representatives. We need the help from the government, the state legislators, the federal government, to help push to make sure that the payers respect this platform as part of our future, the future of healthcare. That will limit us so much in addition to liability and HIPAA issues, but really, for the doctors right now, many practices are suffering. There's a lot of private physicians whose doors have been closed, and this is the only way they've been able to generate revenue. And so I really hope that we can kind of continue to move forward and continue to rely on this as a way to take care of our patients.
Awesome. Thank you. That was really good. So I think we've hit the time. A big thank you to all the folks that were on the call. It was a great discussion. And I think you all provided really, really important and necessary information. The Chamber would like me to call attention to a couple upcoming dates. May 27th, there is a third in the medical update series that will focus on hospital operations and what's going on at that level. And then the State of Higher Education Zoom conference is Friday, June 26th at 11:30. And there are some more events listed on the Chamber's calendar. A big thank you to all of the sponsors and everyone that's attended. Again, the sponsors are CHI St. Luke's here in Sugar Land. And I apologize, I mispronounced earlier. It's CU People. And thank you to Eileen, who was on the call. Fort Bend Medical Society. Again, thank you to Dr. Shaw, who was on the call. And Memorial Hermann Sugarland and Houston Methodist Sugarland. We certainly couldn't do what we do without all of the folks that support the Chamber. So with that said, thank you. Have a great day. Stay calm, be safe, and we will see you next time.
Thank you.